Now, moving on to upper cervical spine injuries. Cervical spine is actually divided into upper as well as lower segment. Upper includes the occiput and C1 junction, then and C1, C2 joint, as well as C1 and C2 vertebra. And from C2 onwards, the C3 and all these vertebrae is included in the lower cervical spine. In this section, we'll be discussing the occipital condyle fractures, occipitocervical dislocation, and C1 ring fractures, which are also termed as Jefferson fractures. We'll be discussing the fractures of C2, which maybe include traumatic spondylolisthesis, in which the vertebral body displaces forward or backwards, or actually slips. Or we'll be discussing as well C2 odontoid process fracture, because which is a very common fracture, especially associated with the C2 vertebra. Coming to the occipital condyle fractures, usually a very high energy trauma injury associated with skull or cervical spine injuries. Diagnosis can be easily missed on the plain x-rays, because x-rays usually, when they're taking AP or lateral view, we rarely take whole of the skull along with it, because usually the idea is to take cervical spine along with the T1. So it can be easily missed on the x-rays, and we need to be very careful when we are looking at it, because there may be associated tenderness over the occipital region. If that is so, we may need to get a CT scan as well, and CT scan is really essential to rule out the exact injury of the occipital condyle fractures or not. This is CT showing a corner view, and if you can appreciate that the occipital condyles are actually fractured on the both sides as well. On an X-ray, they may not appear fractured at all. So that is, if it does happen and if there is an associated occipital condyle fractures, how do we treat it? They treat it by brace immobilization for 8 to 12 weeks, at least, in form of a hollow vest. Hollow vest is usually the most common practice mode. Otherwise, if there's displaced or there is causing neurological compromise, then we may have to go for fixation as well. And the most common way out is the fixation by posterior approach. Now coming to the occipitocervical dislocation, although it's a very rare injury, but if it does occur, it can actually lead to death as well. And it's usually associated with high energy trauma, associated with other serious bone soft tissue injuries, and even the patient may not survive before even reaching the hospital. And the most common way it is actually on the lateral cervical radiograph. There may be associated, not dislocation, but there may be associated subluxation. Now, the subluxation without a neurologic compromise, patient may survive till patient reaches the hospital. But what's important is, if you see this radiograph, you can appreciate C2, C3, this holds the cervical spine. C1 and occiput have actually translated forward over this, and this can be appreciated as C1, C2 dislocation as well. So that is what's important, is when we are looking at the lateral view of the x-rays, we have to look at the anterior vertebral line, posterior vertebral line, spinolateral line, and spinous process line, just to make it sure that there is one vertebra or occiput has actually not translated forward or backward over another vertebra. CT scans are more reliable and they're actually more helpful, and they can be easily helpful to delineate what kind of you can calculate the distances, that is the anterior atlantodense interval along with the posterior atlantodense interval, and that can be more reliable in confirming our findings whether associated with subluxation or it is a frank dislocation. Now coming to the occipitocervical dislocation. Now the C1 vertebra may dislocate from the occiput, and it may require an immediate reduction. If the patient reaches hospital, and most likely the diagnosis is such that once you make the diagnosis, you have to make sure that you have to reduce it, immediate reduction with traction. It may be without traction as well. Why? Because if the patient is unconscious, unless you're sure about it, then you cannot move it. But if the patient is conscious, then you can reduce it without even traction as well. Then it comes the stabilization with hollow vest, and once if you see that patient hollow vest stabilization is adequate, well and good. If it's not adequate, or if the fracture is still unstable, then you may need a surgical stabilization by occipitocervical fusion. Fusion is necessary, otherwise there could be recurrent dislocation or subluxation of the occipitocervical area. And then if this fracture becomes stable with the hollow vest, then we can apply that hollow vest at least 6 to 8 weeks. and patient neck can be immobilized in a hollow vest for 6 to 8 weeks, and then it will be reassessed at times. Now coming to the C1 ring fractures, these are very important because the C1 vertebra is a vertebra which is like a ring which has no actually body. It has anterior arches, it has a posterior arches, and it can get fractured as well. If you see, this is actually the anterior arch, this is the posterior arch, this is the dents of the C2 which is actually articulating with the C1, and these are the lateral masses of the C1 vertebra. Now, ring fractures, these are actually called as Jefferson fractures. And why they're common? They're usually common in axial load burst fracture the ring of atlas can occur. For example, a patient is falling onto a hard surface. This could be falling into water at a very awkward could as well, or there could be falling onto a hard surface, and with the neck actually taking the load of the whole of the body, with the head striking first to the ground and then actually the neck is axially loaded. These kind of injuries can lead to Jefferson fracture, although they not be associated with neurological injury, because at this points at C1 C2 level actually the canal is quite wide, and there may be at least there not associated neurological compromise. But what's important is that this can be an undisplaced fracture or it could be a displaced fracture, and that is why we need an open mouth view of the x-ray, especially to know whether there's isolated anterior arch or posterior arches involved as well, or only on unilateral or bilateral fracture, and then we can apply the semi-rigid collar if it is undisplaced. How to make a diagnosis? As I told you, the diagnosis on x-ray is always on an open mouth x-ray view with the displacement C1 relative to C2 is important. It's usually visible on lateral view, but on lateral view we are actually seeing it from one side, so we are not sure whether both the arches are involved or not, but the involvement of both sides can be easily taken on AP view or open mouth view of the x-ray. Then CT scan is actually required to confirm and define a fracture. Why? Because there may be associated lateral mass fractures as well. There may be a comminuted fracture. Then whether it's displaced, and if it is displaced, how much displaced, that is something which will be visible on the CT only. Now, if you see, this is, I was talking about that when you get a lateral view x-ray of any cervical spine, these are the lines which is important: anterior vertebral line, posterior vertebral line, spinolamellar line, and spinous process line. These lines have to be oriented normally, and then you have to look at the C1, C2, C3, C4, C5, C6, 7, and T1 bodies as well. And why it is all important is because you have to go very systematically, that whether lines are intact or not, whether bodies are intact or not, whether is there any one vertebra which is moving actually slipping forward or backwards over another vertebra or not, is there a fracture of the body or not, and then how that is how you realize it, there could be some kind of a pathology. And so mostly on a lateral view, if you view it systematically, there is less chances of making an error. Especially there's a rule of Spence which actually says if the C1 lateral mass have a combined overhang on C2 of more than 7 mm on an open mouth view, transverse ligament is likely to be ruptured, making injury unstable. So what do we do is, if taken as a ring, and actually the dents is like this, and this is how the C1 articulates over C2. So what they do is that they take the interval from the dents to the lateral masses on one side, and they calculate on the other side as well. For example, it is, if it is 3, it should not be more than 3.5 mm on each side. If it is, let's suppose, more than 3.5 mm on right as well as the left side, this means combined overhang would be more than 7 mm. So that actually tells us that probably not only the LR ligaments, but both the transverse ligament, both the LR as well as the transverse ligament is actually ruptured, and as a result, atlanto-dens articulation is actually disturbed, leading to C1 Jefferson fracture. So that actually means that now once the transverse ligament is ruptured, this means the atlanto-dens articulation will severely compromised, and this requires surgical stable intervention and stabilization. Now, this could be due to hyperextension injury, either anterior or posterior arch of atlas is damaged. This could be simply unstable or stable injury. If it is undisplaced, usually it's stable. If it is displaced, it's usually unstable. And if it is hyperextension and stable injury, it can be managed by a simple cervical collar as well, and associated with almost 50% of the cases of other fractures of other cervical vertebra as well. Now this could be another issue is with the C2 as well. Now C2 can have two type of injuries. There is a dense fractures which is actually covered, or there could be traumatic spondylolisthesis. Spondylolisthesis means slippage of vertebra, and traumatic means can be to high energy trauma. There could be slippage of C2 over the C3. Now this is important that once the C2 slips over C2, this could be is actually correctly referred to as hangman fracture, because hangman during the hanging of the person, when the person hangs is actually during that process there is actually fracture of C2 C3 vertebra, and there's definite dislocation of C2 C3 intervertebral joint, but this is termed as in referred to as hangman fracture, although this is not the hangman type of fracture which actually happens to the hanging of a person. And actually there is associated pars fracture as well of the C2. As a result, due to this pars defect, there may be a slippage of C2 over the C3. May be associated with neurological injury as well, like paresthesia, pain, numbness, and myelopathic symptoms as well. Stability is usually determined by C2-3 disc status and facet integrity, and for that we need the CT as well as MRI. If the C2, C3 disc is intact and the facets are intact, then we'll probably they're stable injuries and can be dealt with a hard rigid collar. But if there is less than 3.5 mm C2, C3 subluxation, which means most likely this is a stable injury, this could occur in an undisplaced fracture, then we can get usually can be treated in semi-rigid orthosis or semi-rigid collar for 6 to 12 weeks. But if it is more than 3.5 mm displacement, which means it's an unstable fracture, then it actually requires reduction, and required reduction can be through the posterior approach and posterior implementation of C2 over with C3. And it could be acute facet dislocation of C2 or C3 as well. Now, if there is acute dislocation, that actually requires an open reduction tunnel fixation via posterior approach, and C2, C3 are actually fused via posteriorly. Now, if you see this is the CT, this is the body of C2. Odontoid actually is a kind of elongation from the body which actually articulates with the C1 over here. There could be a fracture of this odontoid process on the C2 only, instead of having a C2, C3 body fractures. So what is important is that odontoid process can have different fracture patterns. Although it's uncommon, but it can occur, and especially associated with hyperflexion injuries, especially in the case of young adults after high velocity injuries. If there's sudden deceleration, the neck goes forward, there could be hyperflexion of the neck leading to this kind of a fracture. In elderly and osteoporotic people, as a result of low energy trauma, it can occur as well. It must be remembered that in case of rheumatoid arthritis, there could be this kind of an injury leading to severe cervical spine instability, especially the patients of rheumatoid. There is seldom neurologic injury, but as at this stage the canal is quite wide, but we have to remember that this could also be associated with some kind of a neurological compromise. There is actually a D'Alonzo classification, Anderson and D'Alonzo classification for odontoid fractures. Type 1 includes a fracture which involves only the tip of the odontoid. It's an avulsion fracture, and actually it's usually due to traction by LR ligaments. Usually stable, and it's united without difficulty. All it requires is cervical spine immobilization with a soft collar. Type 2 is actually the problematic part, because it's actually a fracture of the base of the odontoid, where actually the odontoid joins the body. And this is actually a watershed zone where there is no actually blood supply. Rather, there is a watershed zone at this level, and this results in a non-union. There is a very high rate of chances of non-union at the type 2 odontoid fractures. Now, coming to the type 3 is actually the fractures which are not involving the odontoid, but also the body of the base of the odontoid, and the body of the C2. Now, this is which a fracture is through the body of the axis, and a fracture is stable and almost always unites without immobilization. So what's important is type 1, type 3 can be easily managed without any surgery, In type 2, we have to be very careful. If there is, it can be managed without surgery, but if it's non-union, then we may have to do some kind of surgery for the non-union of type 2 injuries. Now, what would the clinical feature would look like? Usually they're non-specific and easily missed. Diagnosis is usually confirmed by X-rays. CT may also be required as well. And treatment. Type 1 fractures, as I told you, usually are stable, requires simply a rigid collar until the comfort subsides. Now coming to the type 2 fractures, non-operative for the period of traction followed by collar or hollow vest. But if there is non-union, then you need a surgical treatment for that. In non-union fractures, we need to get a screw out. There is usually open addition internal fixation by use of a lag screw. Now, if there are actually type 2 is further divided into type 2A and type 2B depending upon the geometry of the fracture pattern. If it's type 2A, then we can put a screw that is an anterior screw from C2 body to into the dents so that lag effect can reduce the fracture. But if it's type 2B, the fracture geometry is such that you cannot put an anterior screw from C2 body into the dents. Therefore, what you need to do is you need a compression plate at C2, C3 level so that the actually fracture is reduced like that. Fracture pattern is not conducive, that is if it is 2B, then you need a C1, C2 instrumentation, that is a posterior instrumentation so that the fracture is actually reduced. Coming to the type 3 fractures, type 3 fractures as I told you are those which are involving the odontoid as well as extending into the body of the C2. If they're undisplaced, all they need to be treated in a hollow vest for 8 to 12 weeks. If they're displaced, they may require fixation, and initially they can be reduced by initial traction applied by the hollow vest. If they get reduced, we can keep it there for 8 to 12 weeks. If we are unable to reduce them with hollow vest traction, then they have to be fixed by posteriorly, and C1 C2 fusion needs to be done. For elderly patients, a collar may be suffice because of the low energy trauma and maybe due to the high risk of non-union as well. In this section, I have briefly gone through the upper cervical spine injuries, which include the occipital condyle fractures, C1, C2 fractures. In C1 fracture, the Jefferson fracture, although rare but very important because they may be associated with the injury of the transverse ligament leading to atlantodense disarticulation and instability of the cervical spine. Then of the C2, C3, there may be associated traumatic spondylolisthesis, which is wrongly termed as hangman fracture, but there may be due to slippage, there may be associated cervical spine and neurological compromise as well. There may we also have to look at the C2 dense or odontoid fractures as well, which is highly important. Why? Because in C2 odontoid fractures, especially the type 2, which occur in the watershed zone, are highly prone to non-union and may require a surgical fixation as well. Thank you very much. Keep watching sqadia.com.